Hi there, just a little bit about myself. My name is Michelle Greason, and I am a critical care transport nurse with the University of Vermont Health Network, as well as our base infection control officer. I've been in this position for just a little over 6 years. Prior to that, I worked at the bedside for about 11 years, and that was mostly in trauma ICU, but I also dabbled in all of the other critical care environments throughout the time. Here at HealthNet, we have a fleet of ground ambulances as well as a helicopter for air transports. Between both of those modalities, we transport patients of all varieties, including patients that are our topic of conversation today. That's the RSV patients and our high flow nasal cannula. So in the past, we've been using the airbow unit by OptiFlow, and we've been using that on our ground ambulance transports, but for the air transports, we've not been able to provide high flow nasal cannula at all. And across the board, we've noticed there's a gap in what is available for that pediatric non-invasive equipment. So just to kind of outline what's on the slide, we have some limitations because of the actual space and lack of flat surfaces on the aircraft, as well as our O2 capacity limitations on the aircraft. By ground, now we have the unit on the ambulance, but there's no AC power between the bedside and the ambulance, as you can imagine. And the mobile power packs that are available, those are all third-party, rather bulky and difficult to secure safely. Now, not being able to provide high-flow nasal cannula and non-invasive by aircraft and not being able to do it from the bedside to the ambulance on ground really kind of creates a problem for our patient population. Earlier this year, we started to work on a solution for the air team so that they could transport this patient population, and we landed on the H900 heat and humidification unit from Hamilton. It's the vent we currently use. Now, this also relies on AC power, but it will continue to provide flow and humidification when not plugged in. And when you plug it back in, then the heat aspect also comes back online. Our projected rollout was this winter, but with the rapid uptick in RSV patients right now, we were anxious to find a short interim solution until we get the equipment that we have. So our timeline started back in the spring, and that was when we did the Hamilton software upgrades, ordered the units, and since then we've also been working on creating the guidelines, getting medical director approval, rolling out education, supply chain, and implementation. So with some long hours of our educator working with the PICU team as well as the respiratory therapy department, she was able to develop an interim solution utilizing the equipment we already had in stock and were familiar with, which really helped in the rollout. What we're doing is using our current high flow nasal cannula setup that we use in the ambulance, which comes with the adapter that allows the nasal cannula to be placed directly onto the pediatric vent circuit. And then we add the inline nebulizer to provide humidification. And in conjunction with the high flow non-invasive settings on the Hamilton vent, we're able to achieve the care we were hoping for. Now, we're still lacking the heated humidification, which is not ideal, as we know, but this gets us much closer than we have been, and we can still achieve the same thing with pediatrics as well as our adult population. So one of the challenges that was on the previous slide was our oxygen carrying capacity on the aircraft. Now, our service area can vary greatly up in this area. Some transports are only 10 minutes, while others can be well over an hour and a half by air, or up to 4 hours by ground ambulance. With such a wide variety in flow rates that are used with high flow nasal cannula, a long transport with high flow can really burn through our oxygen reservoirs. And to add to that, our aircraft has a unique sized tank, making it difficult to use the calculators that are out there for O2 consumption. So our educator was also able to put together a chart that gives us a guide how long we have for those transports and depending on the flow rate, and that kind of gives us a better idea on how far we can go and what the patient's needs are. And albeit there are less limitations with ground transports than with air, we still do have to navigate that trip from the bedside to the ambulance. We usually do this by placing the patient on a nasal cannula topped with a non-rebreather until we can get them back into the ambulance and put them on the airbo unit that's plugged in. So now with this solution we've been working with, we are able to transfer therapy right over to our Hamilton vent using that high flow setting and the cannula that they're already wearing. And then when we get back into the truck, we're able to swap them right back over to the airvo, therefore never having to disrupt patient therapy. As far as our timeline that we have been working with this, back in the spring is when we started thinking about our solution, but our short-term timeline, just so you can see how the rollout went, it was about the end of October that we saw a pretty big uptick in RSV transports. By the end of October, we had developed that possible interim solution. By November 1st, we had medical direction approval and additional supplies were ordered. By the 7th, we were rolling out education. Currently, we have had a significant number of RSV patients that we have used this therapy on with really good success. And in the future, we continue to roll out our use of the H900 in the early 2023. Now, if anyone has any questions about our program or how we rolled it out or any of the therapies we're using, I am more than happy to address those with anyone. Please feel free to email me. My email was on the first slide there, and I'd love to go over anything. And so that's about it for this presentation, and thanks for listening.